Hello everybody. Today we are going to discuss about European Society of Intensive Care Medicine Clinical Practice Guideline on Fluid Therapy in Adult Critically Ill Patients. So according to this guideline, if you are dealing with the critically ill patient, it is always preferred to use crystalloid over albumin for volume expansion. So while dealing with the patient with the sepsis, also it is advisable to use crystalloid over albumin. So while dealing with the patient with the acute respiratory failure, also crystalloid is preferable choice rather than albumin. But if you are dealing with the patient with a traumatic brain injury, it is advised to recommended isotonic saline preferred to albumin. So while dealing with the patient of perioperative period, or if the patient is in bleeding or the risk of bleeding, the crystalloid is better choice than the albumin. But yes, if you are tackling with the patient of the cirrhosis, then the albumin is preferable choice than the crystalloid. So till now we have seen the recommendation whether we should go for crystalloid or albumin. Now we will see whether crystalloid is better choice or normal saline. So what they're saying is balanced crystalloid rather than isotonic saline for volume expansion is better in adult critically ill patient. So why? Because as we all know, normal saline is known to cause hyperchloremia, acidosis, and the further renal failure. So if we have the shortage of balanced crystalloid solution, then yes, of course, this normal saline is the better choice. But we have to see the underlying condition, whether the patient is prone for metabolic acidosis or if there is already hyperchloremia. Then in this condition, normal saline is not the preferable choice. The preferable choice is always crystalloid. But if the patient is in the condition like hypochloremia, metabolic alkalosis, then yes, we can go for isotonic saline. So the next is whether balanced crystalloid versus isotonic saline in conditions of sepsis. So again, according to this guideline, crystalloid is always better than isotonic saline if we are dealing with the critically ill patient in sepsis. So what we should do in traumatic brain injury, crystalloid or isotonic saline? So according to this guideline, isotonic saline is better choice than balanced crystalloid for volume expansion if we are dealing with the patient of traumatic brain injury. So for traumatic brain injury, at least we have only one answer, that is isotonic saline is always better than the any other fluid. So what we should do if we are dealing with the acute kidney injury, should we go with the crystalloid or should we go with the isotonic saline? So in this condition also, balanced crystalloid is always preferred for volume expansion. So should we use the small volume hypertonic or isotonic crystalloid for volume expansion in adult critically ill patient? So it is advisable to use isotonic crystalloid rather than small volume hypertonic fluid for volume expansion in adult critically ill patient. Now we'll see what are the recommendation in sepsis. So sepsis, it is always if the patient is in sepsis or septic shock who require fluid resuscitation, then it is advisable to use 30 ml per kg of intravenous crystalloid in the initial phase when hemodynamic monitoring is not yet available, typically within the 3 hours. And then after giving this initial fluid, we have to really assess whether the patient is fluid responsive or not. And the further resuscitation is always depending on the fluid responsiveness of this patient. So clinician should assess clinically and consider the fluid responsiveness always. So if the patient is fluid responsive, then we should go for the further fluid resuscitation. If the patient is not fluid responsive, then we should not. Then there is no point in administering extra fluid to that patient. So, in adult with the septic and septic shock who need fluid resuscitation, we cannot recommend it for or against systematic restrictive or liberal fluid resuscitation. So it's not like the in septic shock we should follow some restrictive or liberal fluid resuscitation. It is entirely depending on the fluid responsiveness of the patient. So there is nothing like we should follow the restrictive fluid strategy or liberal fluid strategy when we are dealing with the septic patient. So the I think the treatment fluid resuscitation in sepsis is clear. So in initial phase, when the patient is unstable, we need to follow 30 ml per kg strategy, but and then we need to assess for the fluid responsiveness. If the patient is fluid responsive, go for the further fluid resuscitation, but if the patient is not fluid responsive, there is no point in giving the more and more fluids. It will cause only harm to the patient. So, the fluid strategy should be individualized. It always depend upon the response of the individual to that particular amount of the fluid. So I hope the sepsis part is clear. So next we'll go for the hemorrhagic shock. So, for while dealing with the hemorrhagic shock, should we go for the restrictive or liberal fluid strategy? So, according to this guideline, in adult with the hemorrhagic shock, after penetrating trauma, it is always suggested to you go for the restrictive fluid strategy compared to the liberal fluid strategy. So also should restrictive and liberal fluid strategy used for the fluid resuscitation in patient with the in critical ill patient with hemorrhagic shock following blunt trauma. So in penetrating trauma, these guidelines is saying go for restrictive fluid strategy. But what if the trauma is the blunt? So it is in blunt trauma also it is advisable to go for the restrictive rather than the liberal fluid strategy. The panel also recommended that in patient with the hemorrhagic of non-traumatic fluid, fluid administration should be guided by hemodynamic and biochemical parameter in the context of primary disease state prior to the definitive fluid hemorrhage control. Now, the biochemical parameter that we should monitor is metabolic acidosis, hypothermia, platelet count, and coagulation factor when we are doing the fluid resuscitation. So, when we are dealing with the hemorrhagic shock, so depend upon the type of the trauma, like penetrative trauma and the blunt trauma, we should always go for the restrictive fluid approach. So, and again, here we need to see the physio biochemical parameters like acidosis, hypothermia, platelet count, and coagulation factor while assessing the response to the fluid. Now, the next is obstructive shock. So, this panel recommended that in adult patient with the circulatory failure due to pulmonary embolism, clinicians should be cautious about administering fluid and should base their decision on measured surrogate markers of right heart congestion. Also, if circulatory failure is because of the cardiac tamponade, the fluid should be given cautiously as a temporary measure until definitive management can be undertaken. Now about the left-sided cardiogenic shock. In adult with the circulatory failure due to left-sided cardiogenic shock, it is advisable that fluid resuscitation should not be the primary treatment. Now, while dealing with the patient of acute respiratory distress, in patient with the circulatory failure and ARDS, it is we cannot make the recommendation about the volume of the fluid administration. So while dealing with the patient with the ARDS, so according to the trials like FACT trial, it is already proven that the restrictive fluid strategy is better than the liberal. But what we are following in the clinical practice. So fluid resuscitation should always be liberal for first 48 hours when the organ perfusion is compromised, because we are dealing here with not only ARDS but also with the circulatory shock. So after this, when that 48-hour period is over, 48-hour critical period is over, when the organ is optimized, we can follow this restrictive fluid strategy. Now about the deresuscitation. We suggest the deresuscitation of the fluid therapy over no deresuscitation in critical ill patient after acute phase of the fluid resuscitation. Also, we should always follow the protocolized fluid removal by diuretics over usual care in critical ill patient after acute phase of fluid resuscitation. Also, we should, but for deresuscitation, we should not follow ultrafiltration or extracorporeal fluid removal after acute phase of fluid resuscitation without an indication of RRT. Thank you, guys.